Now we see investigating the cardiovascular system. Now when you investigate, you've got different type of modalities available to help you see what's going on in any given organ system. So you've got labs, you've got structural imaging and functional imaging in case of cardiovascular system. Now what sort of labs which can help in cardiovascular disorders? Troponin is good. Like if we synthesize this, we can have more tests which can help us. For example, tests which can identify risk factors for presence of heart disease. When you say heart disease, generally it is coronary artery disease, which is the most common form of heart disease. You see, there are other diseases like disease of the muscle, the pericardium, the valves, the blood vessels. The most important disease in the heart is the coronary artery disease, or what we call the ischemic heart disease. So we can have tests which can identify risk factors. For example, blood sugar, lipids, proteinuria. Proteinuria is associated with increased risk of coronary artery disease. Patients who've got hypertension, those who've got renal disease, those who've got proteinuria because of these problems, diabetics, they tend to have more of coronary artery disease. Then thyroid disease, homocysteine, complete blood count, and then you can have disease markers now which you talked about. This is in the ambit of disease markers. Inflammatory markers like high sensitive CRP. You know, the high sensitive CRP relates with the presence of atherosclerotic cardiovascular disease, because atherosclerotic cardiovascular disease is possibly an inflammatory disorder. And then you get cardiac biomarkers, myoglobin, creatinine kinase, SGOT, LDH, troponins, troponin T and I, which you mentioned, and then N-T-terminal of the pro-BNP. So you can use these as markers of the disease. And then you can have some tests which may help you to tell what's the possible cause of this disease. For example, viral markers. Viral markers, you see which diseases in the heart you're looking for viral markers. Myocarditis, good. Pericarditis. So you may go for viral studies if you got acute myocarditis or pericarditis, and then the blood cultures. These may help you identify what's the causative organism in cases patient have infective endocarditis. So this is how you group your labs. You want to identify risk factors, you see disease markers, biomarkers, and then you got some etiological tests. Now we come to the more important studies. These are the imaging studies. Which imaging studies you can use in the cardiovascular system? Again, identify, group things. Then now you can have electrical imaging of the heart. This is the most important. What do you understand by electrical imaging? Electrical imaging is not echocardiography. It is ECG. It tells you how the current is flowing. If you see the 12-lead ECG, you can have an electrical image in your mind that what is going on in the heart. The electrical changes in the heart, they give you a lot of information. So the most important is electrical imaging. And the 12-lead ECG is the most important, and in some cases we need electrophysiological studies. For example, if the patients have abnormal rhythms, spells of tachyarrhythmias like supraventricular tachycardia, so the electrophysiological studies may also be useful. So this is the most important imaging study. In this, you do not see image like this. You have to visualize how is the current moving inside the heart. This gives you electrical image of the heart. So this is the most important, and we are going to discuss in detail this test today. Then you've got ultrasonic imaging, like you mentioned, echocardiography. You can have Doppler studies which can show you the flow of blood and in the heart and in the blood vessels. The Echo tells you the structure of the heart and the flow of blood in the heart. And then you can have nuclear imaging like thallium scan. Radiological imaging, chest X-ray, CT, catheter studies, and the latest addition is MRI, the cardiac and vascular imaging using magnetic resonance imaging. So these are the tests which are used for structural imaging. Functional imaging is actually used by using these tests and deriving about the function of the heart and how the heart is functioning using basic investigation modalities. For example, treadmill testing uses ECG. The treadmill tests you about the functional capacity of the heart, but it uses the basic modality of imaging like ECG. Similarly, the echocardiography, nuclear imaging, and catheter studies can give both structural and functional information. So using the catheter studies, you not only see the anatomy of the coronary arteries, you can also see the functioning of the left ventricle. How is the left ventricle working? So you can see both functional and structural information can be obtained from these different type of modalities. So these are the different testing laboratory assistance we need for patients who got cardiovascular diseases. Now ECG is the most important. What is ECG? Very intelligent. I'm not asking you what is the abbreviation this word is of. I'm asking what is ECG actually. So good, this is the electrical activity of heart recorded from the surface of the body. So this is the most important investigation when you're considering cardiovascular system. The single most investigation you should need to know thoroughly. At least in final year, you must know the basics of ECG, and as you pass the final year, you go into the your clinical training in house job. You will encounter ECG in emergency in every specialty you are working. It's medicine, it is surgery, it is orthopedics, it's anything. You are going to see an ECG. So you should be aware of this ECG. Similarly, you should be well aware of chest X-ray. Recording of electrical events of heart from the surface of the body. Now we'll see in this lecture what are the basics of ECG, rate, rhythm, calculation, axis, hypertrophy, ischemia. This I will not discuss in detail. You can see it in the books. So we'll discuss up till here. Now the standard ECG is 12 lead ECG. There are 10 electrodes which are placed. One electrode is attached to each limb and 6 electrodes are attached to the chest. So you've got 4 limb electrodes and 6 chest electrodes. So the machine is so designed that it gives you 12 leads. जो मशीन के अपने अंदर जो उसका सॉफ्टवेयर है या उसका जो प्रोग्राम है वो इन 10 लीड्स के बदले आपको 12 लीड्स ECG की ट्रेसिंग के ऊपर देता है. वो सारा सिस्टम मशीन के अंदर डिजाइन किया हुआ है, उसकी डिटेल में जाने की जरूरत नहीं है. The left arm, right arm and left leg electrodes are attached to a central terminus acting as an additional virtual electrode in the center of the chest. ये वो ट्रायंगल याद है? So ये वो इलेक्ट्रोड है जो वर्चुअल, ये मशीन के अंदर डिजाइन किया होता है. So ये बाहर से आपको नजर नहीं आता. This is an earthing electrode. Now this is the axis of the limb leads. Remember 1 and AVF. Normal axis, cardiac axis lies along which lead? So it's along the limb lead 2. What is exactly the normal axis of the heart? Is 59 degrees. The lead 2 is 60 degrees. So we assume that normal electrical axis lies here, but it can vary between these two extremes. So you remember, one is at 0 degrees and AVF is at 90 degrees. This is the positive pole of AVF, this is the negative pole. This is the positive pole of 1, this is the negative pole of 1, this is at 180 degrees. Then you got chest leads. V1 to V2 septal leads, V3, 4 anterior, V5, 6 lateral leads. Just remember these will be very useful when we are dealing with ischemic heart disease. Now ECG paper, you have seen ECG paper? It's a grid-like structure. You see small squares and you see bold large squares. Large square on horizontal axis mean 0.2 seconds and on vertical axis it is 0.5 volts. So small square is 0.04 seconds or 40 milliseconds. So it means 0.2, this is a one large square. So in 1 second we will have 5 large square, is it? So 1 second will be 5 large squares. This will be required when we are calculating the heart rate from the ECG. Now standardization. Speed we use is 25 centimeters per second. Sometimes we also use 50 centimeters per second. For example, if you have got a tachycardia, narrow complex tachycardia, the complexes are so close that you are unable to find a P wave. You run it at a double speed, the complexes they separate. And the individual components of the QRS complex, they become more visible. So in that case, we use the double speed. Normally we use 25 centimeters per second. The normal ECG you see is on 25 centimeters per second. But when you read ECG, you should see what's the speed on this ECG. Usually it is written on ECG paper in the modern machines that this is running at 25 centimeters per second. And then over and under damping. This is seen in classical machines which use the fax type of paper. Now we have got machines which use the electronic printers, but there are machines still being used which use fax-like paper. You know what is the characteristic of fax-like paper? It is covered with a wax, and there is an electrode which is actually a stylus which gets heated up when the current passes through it, and it's the heat which gives you the line on the paper. So if the stylus is too tightly pressed in the paper or too gently pressed in the paper, that's going to give you a problem. So to see if the machine is working, you see over and under damping. How do you see that? Have you seen the ECG, any ECG? You would have seen a small box-like wave in the beginning of the ECG. That box should have perfect squares. It should be exactly square. It should not be like that, rounded, or it should not be spiking. If this is like that, this means this machine is not standardized and it is going to give us false wave formation. For example, if it is too tightly pressed, it is going to give us, on the upstroke, it's going to give us a curve. That means the height of your R wave will decrease. The height of your waves will decrease because that is too close. Instead of going up, it remains beneath that maximum excursion it can get, and you will get lower waves. Similarly, you can get, if it is underdamped, you can have deeper S waves, which may appear like Q waves sometimes. So it gives you problems. So when you see the paper, you see exactly the standardization is there. The standardization box is normal. If the standardization box is not normal, your ECG interpretation may not be correct. Then lead placement. Limb leads, chest lead, right-sided leads. What are these right-sided leads? Normally you place chest leads like that. V1 is here on the right side and you proceed like that. In right-sided lead, you proceed like that. Why do you need right-sided leads? You don't need it in dextrocardia. Dextrocardia can be diagnosed on standard placement of the leads. if there is inverted P waves in limb lead 1, that means this is dextrocardia. There are other features as well, but this is a very strong point. If the lead placement is correct and the limb lead 1 shows inverted or downward directed P wave, this is dextrocardia. There are other features like the V1 may show an upstroke. So right-sided leads are done because we want to see in inferior wall myocardial infarction. The inferior wall myocardial infarction is because the problem is in the right coronary artery. The right coronary artery also supplies the right ventricle. If there is infarction of the right ventricle, there are changes in the right side of the chest leads. So we need right-sided chest leads if the patient has inferior wall myocardial infarction, has a high JVP, you give nitrates or diuretic, the blood pressure drops. So you need to have RV leads done to see the right ventricular infarction because the management is slightly different. In RV infarction, you do not give nitrates. In fact, you give 300 to 400 ml of normal saline so that the right ventricular pressures are high and the right ventricular pressure is output is maintained. So in that case, you need right-sided leads. Otherwise, if there is an anterior wall infarction, you do not need right-sided leads. Now, these are the normal waves, interval, and segments. I presume you know already all this. Do you? That's good. If the current is moving toward a lead, it shows an upward deflection. If the current is moving away from the lead, it shows a downward deflection. This simple principle has to be kept in mind. Now, how do we calculate rate and rhythm on ECG? First, we see how do we see the rhythm. How do we see the rhythm? So we can see it in any lead. So distance between same waves of adjacent complexes is similar between any two consecutive complexes. So we take, suppose, the peak of the R wave. The distance between two adjacent R wave peaks is same for anywhere we measure it. We take the first and second R waves, we take second or third, we take third or fourth. The distance between these two adjacent peaks is same. So this is the rhythm. If the distance is not the same, it means there is some rhythm disturbance. So calculation of rhythm is simple. Now how we calculate the rate? How we calculate the rate? So 300 divided by number of large boxes between two consecutive peaks of the R waves. So the words should be, this phrase should be complete, because if you say between two R waves, what's two R waves? So it is in patients who got a regular rhythm, that's why we did the rhythm first rather than calculating the rate first. If the rhythm is regular, this formula can be used. 300 divided by number of large squares between peaks of adjacent R waves. But what if the rhythm is not regular? If the rhythm is not regular, if it is irregular, for example, if the patient has atrial fibrillation, how would you calculate the rate then? You cannot use this formula.
10 seconds की strip लेते हैं number of R waves 675.
Number of QRS complexes in 30 large boxes multiplied by 10.
दोबारा बोलो.
Number of QRS complexes or R in 30 large boxes.
So you take a 10-second long strip and calculate the number of QRS complexes, multiply it with a 6. So this is rate calculation in a regular rhythm. You can see that. Number of QRS complexes in a 10-second strip multiplied by 6. Now what will be the 10-second strip? How many large boxes? 1 second means 5 large boxes. 10 second will mean 50 large boxes. ऐसे ही है. 5 multiplied by 10. So it is not 30, it is 50 large boxes. So you can calculate. So this is an example of patient having atrial fibrillation, and this is a 10 centimeter strip. You multiply it with a 6, you can get the heart rate. Then electrical axis. This is the normal axis. This is left axis deviation, this is right axis deviation, and this is called indeterminate axis between 180 and minus degrees. This is extreme right axis deviation. It is sometimes called indeterminate axis. So you can have normal axis, left axis, right axis. How to diagnose these? This represents the overall direction of the heart's electrical activity. It's a sum vector. It is not the anatomical direction of the heart. It is electrical direction of the heart. It is not that if there is left axis deviation, that does not mean the heart is rotated anatomically. Heart is lying in the same place. Only the movement of current is affected. Generally, it lies along 59 degrees, but there are large variations. Now, how to calculate? We call it quadrantic approach. Use 1 and AVF. That's what I said. Remember, 1 is 0 degrees, AVF is 90 degrees. So we use these two leads. This is lead 1, this is AVF. If lead 1 is positive, that means upward, and lead AVF is also positive upward. This is normal axis. If lead 1 is positive, AVF is negative, that is AVF is downward. This is left axis. If lead 1 is negative, lead AVF is positive, this is right axis. If both are negative, this is indeterminate axis. So this is how we calculate the electrical axis. We use, if both 1 and AVF are upright, this is normal. If 1 is positive, the other one is negative, AVF is negative, this means this is left axis deviation. Now what do you see in this ECG? Where is the axis? What do we see? Lead 1 is positive. Lead AVF is also positive. So this is a normal QRS in 1 and AVF. This is a normal axis. Now we see the hypertrophy of the chambers. In fact, in atria, there is atrial enlargement, while actually muscular hypertrophy is seen in ventricles. So you see atrial enlargement and ventricular hypertrophy. Now how do we see atrial enlargement? Left atrial enlargement. We use limb lead 2. P wave is broader than 120 milliseconds in limb lead 2. It's notched like an M. So this is left atrial enlargement. This is, you see, M-like pattern here. And then you got right atrial enlargement. P wave taller than 120 milliseconds in limb lead 2. Either it is broader than 3 small squares or it is taller than 3 small squares. If it is broader, it's left atrium. If it is taller, this is right atrium. You can see this P wave is taller vertically. So this is longer horizontally. This is left atrial enlargement. This is right atrial enlargement. Now comes the most important, left ventricular hypertrophy. How do you calculate left ventricular hypertrophy? You use multiple parameters. Left axis deviation, AVL is greater than 11 millimeter tall. There is left atrial hypertrophy, ventricular activation time greater than 40 milliseconds. What is ventricular activation time? This is also called intrinsic deflection. What is this? If you see the QRS complex, the R wave is like this. Okay? Yeah, it is starting here, it's peaking here, and it's ending here. So the distance between this start and the peak, this distance, if it is more than 1 small square, it means this is abnormal. This is called intrinsic deflection or ventricular activation time. If it is more than 40 milliseconds, it is abnormal. When it will be broad? when there is a thick muscle and current takes a longer time traveling in this muscle. हाँ भाई. So we see the ventricular activation time if it is more than 40 milliseconds. And then voltage criteria. If the sum of SQ wave in V1 and R wave in V6, the V1 shows a downward deflection and V6 shows upward deflection. And if you combine these two, if you add up these two, if it is 35 millimeters or more, this means this is abnormal. And then you've got STT changes. The S segment is depression, T wave is inverted. So if these are present, you can calculate. Each is given one score: 1, 2, 3, 4. This is given 2 scores, and another 1. So 1, 2, 3, 4, 5, 6, 7. Out of this, if its score is 3 or more, this is left ventricular hypertrophy. Simply, at times we use only this voltage criteria. If the sum of S wave in V1 and R wave in V6 is more than 35 millimeters, we say this is left ventricular hypertrophy. But to be very precise, we use these criteria. 3 out of 7 the patient has. This means this is left ventricular hypertrophy. And then you got, this is an example of left ventricular hypertrophy. And then you can have right ventricular hypertrophy. R wave in V1 is greater than 7 millimeter or RS ratio more than 1. That means the R is bigger than the S wave in lead V1. So इसलिए हम V1 use करते हैं. If the R wave, that is upward deflection in chest lead 1, is 7 millimeter or more, this is possibly a right ventricular hypertrophy. Or if the R wave S wave ratio is more than 1, this is. But there are certain conditions that there should be no other cause of R wave in V1. For example, posterior wall myocardial infarction, right bundle branch block, WPW, lead misplacement, isolated posterior wall hypertrophy, Duchenne muscular dystrophy. They can all produce R wave in V1. So first condition is that there should be R wave in V1. But the second condition is all these conditions should not be present. ST segment depression and asymmetric T wave inversion in V1 to V3 indicates strain in the right ventricular hypertrophy and high pulmonary pressure. So this is also a very good contributing factor if there is ST segment depression and asymmetric T wave inversion in V1 to V3. So the diagnosis of right ventricular hypertrophy is with this, and the left ventricular present. This is hypertrophy. For hypertrophy, you not only have high voltage in V1, you also have the absence of other conditions because they can also produce R waves in V1. So this is RV hypertrophy. You see, this is V1. Now, what is J point? What is this J point? J? हाँ? जहाँ पे QRS खत्म होता है और this is J point. This J point is important because if there is elevation is a J point indicates. When we see ischemia, we see groups of leads because ischemia in the territory of blood vessel. Blood vessel is going to supply blood to a specific area. So if the blood vessel is occluded, that specific area will be abnormal and we can see changes in that abnormal area. So the leads reflecting that area will show changes. So if you got a group of leads which shows changes in ischemic heart disease and we find that only one lead is showing problem, the other of the group are showing problem. So it's not carrying any weight. It's actually the whole group should be similar changes. So lead 2, 3 and AVF, they represent the inferior wall changes and they are because of the right coronary artery and sometimes in the left circumflex artery, circumflex artery big. 1 and AVL, they represent lateral wall changes, left circumflex. V1, V2, proximal LAD, V3, V4, the whole LAD, V5, V6, right from the beginning, distal LAD, left circumflex, or sometimes right coronary artery. If the right artery is big, it can come from behind and supply the lateral part of the heart. So in that case, right coronary artery is dominant. V1 to V6, if there are problem, means the left main stem is in trouble. V1 to V3, right coronary artery or left circumflex artery represents posterolateral wall changes. These are represented by reciprocal ST segment depressions. Now, ischemia is usually indicated by ST changes, elevation, acute infarction, depression, maybe infarction or only unstable vagina. So if this is elevation, that generally means infarction, but depression may mean there's infarction. As T wave changes. What ischemia occurring in the past is presented by the Q waves. Now, components of ischemic complex. What are the components of ischemic complex? There is a Q wave which is dead or infarcted zone. Sorry, it's not Zine, it's infarcted zone. That is infarcted zone right in the center. Then convex ST segment elevation, that means injured area. And T wave inversion, that is ischemic area. So this is dead area, this is injured area which is viable, which can be recovered, and this is ischemic area which is still not injured. You can see all this in complex. Can you see this? There is a Q wave, there is an ST segment elevation, there is a T wave inversion. So this represents the whole ischemic complex components. What's the diagnosis in this ECG? So you see there is ST elevation. This is lead 2, lead 3, and you can also see it in lead AVF. So the diagnosis is acute inferior wall myocardial infarction, the ST elevation in lead 2, 3, and AVF. Now you see the changes are present in all leads. Now it's not possible if there is an inferior wall infarction. The lead 2 is showing ST elevation, and lead 3 and lead AVF are dumb. They will also be showing some changes because this is the area which is supplied by the same coronary artery. So it means the changes of ischemic heart disease are usually seen in a group of leads. An isolated single lead showing a change is usually not very significant. It should be supported by similar changes in other leads as well. And then you got non-ST elevation ischemia. Components of there may be ST depression with symmetrical T wave inversion. There may be only T wave inversion. There may be flattening of T waves. So ischemic heart disease, it is very important that you do ECG sequentially, or if the patient has symptoms, a single investigation or sometimes even a single blood test may not be diagnostic. So if a patient you suspect has risk factors, the pain is typical or the clinical presentation is typical, ECG is normal, wait and do not discharge the patient. Do a subsequent ECG and you see if there is a change in ECG. This is very, very significant. So a spot ECG may not be truly representative of the underlying clinical state. So in these patients, do not discard them, just keep them so that you are sure that there is no trouble. So get a serial ECG. And the U wave may appear there, also indicate ischemia. Now in this ECG you see there are depressions here. So again inferior leads, and you got something in here as well. So this indicates a non-ST elevation situation. जब आप ischemic heart disease को divide करते हैं ना, या ACS को divide करते हैं coronary syndrome को, आप उसको दो में कर लेते हैं, through and through infarction and non-ST elevation MI, an unstable angina. So this is a non-ST elevation situation. Then miscellaneous changes, I told you are not going to discuss this in this lecture. We'll see the individual diseases. When we'll see pericarditis, we'll see what are the ECG changes of pericarditis. So we're not going to discuss it here. Now, using ECG, we can have functional status of the heart using subjecting the patient to physical stress or even pharmacological stress. We can evaluate the functioning of the heart. So this is called stress testing. Determine the cardiac performance in situation of physical stress. Emotional stress में ये कर सकते हैं? Is it possible? बड़ा मुश्किल है. How would you put the patient in emotional stress? So it's usually done in the physical stress, and as I mentioned, sometimes we can also use pharmacological stress. For example, if the patient is not able to physically, you've got knee problem or back problem, not walk on treadmill, so we can use pharmacological stressing. Dobutamine use करते हैं उसके लिए. It is carried out on a treadmill or a stationary bicycle. Pharmacological stress like dobutamine can also be used to put the myocardium in stress, and it can be done. Indications are diagnosis and prognosis of cardiovascular disease, specifically coronary artery disease. इसके अलावा किसी और disease में use कर सकते हैं. It is very dangerous if you use in that. Cardiac arrhythmias के अंदर ना, if exercise-induced arrhythmias they start, they can be a trouble. So we do not generally use in arrhythmias diagnosis. Contraindications: acute MI within 2 days, unstable angina, symptomatic severe aortic stenosis, uncontrolled symptomatic heart failure, acute pulmonary embolism or pulmonary infarction. यहाँ पे ना आप हुक्म जो होता है hypertrophic obstructive cardiomyopathy, anything which is obstructing the left ventricular outflow tract is an indication for doing acute myocarditis and acute aortic dissection. The absolute contraindications for doing treadmill testing. The relative contraindications are left main coronary stenosis. I think in this should also be avoided. This is a very serious condition because if left main coronary artery is obstructed, almost all of the LV is gone. Moderate stenotic valvular heart disease, electrolyte abnormalities, severe arterial hypertension. If the blood pressure is more than 200 or diastolic more than 110, you should think of before doing this test. Tachyarrhythmias, bradyarrhythmias, hypertrophic cardiomyopathies, and mental or physical impairment leading to inability to do the exercise adequately. High degree of AV block, that is third heart block, or one second degree of heart block test should not be done. And then indications for termination: when we are going to terminate, drop in systolic blood pressure. A hypotensive response is very serious. It's more serious than a hypertensive response. A hypotensive response means the coronaries are not really very good. Moderate to severe ischemia, angina, increasing chest pain, increasing nervous system symptoms like ataxia, dizziness, or near syncope. Signs of poor perfusion like development of facial pallor, cyanosis. Technical difficulties monitoring ECG tracing or monitoring the blood pressure. Subject's desire to stop. Patient says, I can't do any more, stop it. ST or QRS changes such as excessive ST segment depression or ST elevation or marked axis shift development, the test should be stopped. Arrhythmias like sustained ventricular tachycardia, multifocal premature contraction, triplets, SVT, heart block, or bradyarrhythmias, the test should be stopped. Fatigue, shortness of breath, wheezing, leg cramps, claudication, development of bundle branch block, intraventricular conduction delays, and hypertensive response, the test should be stopped. The interpretation should include the patient's exercise capacity, clinical hemodynamic response, and ECG changes. Now these are a few type of ECG changes which can be seen in treadmill. So this is downsloping ST segment depression, this is ST segment elevation, this is upsloping ST depression, and this is the appearance of the U wave. So these different type of ECG abnormalities may be seen. So if you see or the patient complains, the ECG test should be stopped. And the interpretation subsequently can be done when you analyze the whole ECG. You can give final result that this stress test is positive for exercise-induced ischemia or not.